interviewing for our next fellow, so I'm doing it for you instead. I have his presentation, but it's very complicated.
Oh, I think
Because
the only one that can follow is probably me. But I'll try to kind of understand.
Yeah, so there was another presentation that I actually used for spine biomechanics when I was doing my FRCS revision, and that's the one that I'm going to present. It was done by, it was actually not made by me, it was made by a chap called Mr. Chopra, who's now, I think, a consultant in Wales. He's a really good guy, I know him from the circuit. But he'll be doing, I'll be nabbing his talk, and I'm sure he won't mind. I saw it earlier on. I still have my FRCS revision folder from many, many years ago. Here we go, that's the one. Fine. So, give it a few moments to return on. Just downloading it. Okay.
That is definitely not anything.
Fine. Oh, what's going on here?
It says trauma. It says biomechanics.
Let me just download it and put it on my. desktop.
Hey, just in time. Okay.
Have a nice match.
Sit here because it don't look like that.
Yeah, that's true.
All right.
It's sort of a seats that we never choose.
I think we're now in business. Okay.
So I was.
So, in this talk, we're going to talk about a few things. We're going to talk about your basic spinal anatomy, your regional variations, kinematics and kinetics. Does anyone know the difference between the two, kinematics and kinetics? Iris, do you know the difference between kinematics and kinetics? No, clearly. Anil, do you know?
Is kinematics?
One is to do with movement alone, one is to do with movements and forces. Okay. So kinematics is looking at movement alone, ignoring forces, mass and weight and things like that. Okay.
Sorry, which is which?
Kinematics is movement alone. Kinetics is to do with forces and mass and weight. So we don't need to look at that. So what is the spinal motion segment? Nelson. Carl.
So it's the smallest functional unit of the spine that behaves like the whole spine.
Yeah, exactly. So what is
the
that?
vertebrae, an intervertebral disc, and another vertebrae, and the
Perfect. Exactly right. So motion segment is the bone above, bone below, and the disc in between. Okay. All right. So the parts of that which can, which we need to know about. I mean, I don't need to label these things for you. Can anyone point out where the pars intraarticularis would be? Do you know what the pars intraarticularis is?
Space between the disc, not the disc, the two facets.
Correct. It's the bone between the superior articular process and the inferior articular process. Is Carl the only one who's with me, or are you guys all? You guys know what I'm talking about? Nelson doesn't. That's okay. Anil, do you know what I'm talking about? Just about. Iris, Swan. Okay. So let's go a little bit back to basics. Parts of a vertebra. Okay. You have a vertebral body at the front. Yes.
Yeah.
And then you have, this is the bone we're talking about. It has two projections at the back called the pedicles. Yes.
Yes.
And then the pedicles connect up to the posterior. Pedicles are part of the posterior elements. But then you have connections from the pedicles into the lamina. At the edge of the lamina is the facet, and up from the pedicle is the superior articular process. Down the pedicle, past the pars, is the inferior articular process. Right? Those are the facets. Okay? And the inferior articular process of one articulates with the superior articular process of the one below, and so on and so forth. The pars is that bit of bone that connects the upper articular process to the inferior articular process. and it's a very discrete bit of bone that doesn't have any muscular attachments. Okay, it's important because structurally it's a very important piece of bone, and pathologically it's also very important. And anatomically it's important when you're operating because it helps you navigate. If you know where the pars is, and it's very easy to identify even in degenerative situations, usually. Easy is a strong word, but yeah. So here we've got the vertebral body that we've shown you here. We've got the supraarticular process, the infraarticular process here, and the bit in between would be your pars intraarticularis. Okay, which is not labeled here. That's good because I want to ask you where is the pars intraarticularis. All right. So your vertebral foramen is here. Yes, you can see it's underneath one pedicle and above the other, and it forms a discrete hole through which the nerves come out. Okay. So at L3-4, which nerve will come out? Anybody? We really want to go home, so quickly answer, quickly go home. At L3-4, which nerve is coming out? This is medical school.
L3.
Which one?
L3.
L3, correct. Fine. When you have a disc problem at L3-4, which nerve is commonly affected? Correct, that's what I mean. What am I getting at here? Is it one discrete nerve that is just sitting in this foramen and nothing else? Or is this level associated with varying anatomy depending on how far from the midline you are? Obviously the latter, right? We'll come to that in a bit, okay? So there are three components to the spine, okay? Three components that contribute to spinal stability. First of all, before we go into it, can anyone define stability for me? Who's done the exams? You've done them. But FRC is completed, so how do you define stability?
So you didn't get asked a question.
You do, you know.
So it's
There's three
the ability
factors.
of the spine to be able to function under physiological load, to be
Yes,
not
to
cause
be
pain,
able to bear physiological loads, and then?
and not deform
Yeah, no, without deformity and without
pain.
pain, correct. So those three criteria have to be met for stability. And there are three types of structures which contribute to this kind of stability. One are the passive structures in the spine, then you have the active structures, then you have the neural structures. So Carl, what's a passive structure that contributes to this?
This is a ligamentous structure. So
Yeah, ligamentous structures, joints, bony architecture. Anil, what's the active structures?
So surrounding musculature.
Yeah, okay, so name me some muscles.
So iliopsoas
Yeah,
anteriorly.
yeah, and then what else is there anteriorly just in front of the TP? Quadratus,
Quadratus femoral.
lumborum.
Lumboris.
Okay, yeah. And at the back, Nelson, three lots of muscles, you can give two names if you like. Multifidus, closer to the midline, and erector spinae, away from the locus. Okay, there's two lots of muscles. And the neural elements are your nerves, okay? So this is another diagram looking at a vertebral body. So this is actually, which level do you think this is? Do you think this is lumbar or thoracic? There's a giveaway. Why is this not lumbar or cervical?
the orientation of the facets.
Yeah, good. Spinous process is looking like it's pointing down and is very long. That's one thing. But there's another dead giveaway.
Orientation of
What is this? What is this?
Articulation for the rib.
What is? Yeah, it's a rib articulation. Does lumbar spine have rib articulation? No. So yeah, you're right. You can look at all those other things. The arcade of the varying, the changes in the shape and orientation of the facets is absolutely right. But it's easy, even easier than that. The rib process doesn't exist in anywhere but the thoracic spine. Okay. Fine. So what is this then? Is this thoracic, lumbar, cervical? Lumbar. Why is it lumbar?
The body is quite
Sorry?
large. Large body.
Large body. How about? You don't really know.
It's
because
the orientation of facets.
yes. So large body is correct. If you had a small one next to it, then you could say this is large. You don't know that. But it's the orientation of the facets. What else do you not have here? It was not going to be thoracic, right? But what else do you not have? Then you know it's not cervical.
It's not foramen.
No vertebral foramen, right? So that's why it's lumbar. So there are many reasons, many ways you can tell. Now it's an artificial situation to be handed a vertebra and say, was this lumbar, thoracic, or cervical? But realistically, even if you are handed a vertebra, it should take you less than 1/10 of a second to identify which level it is. It's very easy. And those are the kinds of things you look for, okay? And if you can't, you need to spend a bit of time with the spine to look at it. It's very easy, it's not difficult. Fine. So I don't need to tell you about pedicle screw trajectories, but we'll look at the intervertebral disc, right? So can someone, without looking at this, which gives you some of it, tell me a little bit about the intervertebral disc. What's your name there, sir?
I'm George.
George, where are you from?
I'm shadowing a doctor here. I'm from Singapore.
Oh, very good. Okay, it's not fair to really ask you a question. You're a medical student.
No, I'm doing my A-levels now.
Oh my
The
God.
equivalent.
Okay, fine. Sorry, man. I'm not gonna pick on you. Probably. All right. Tell me about intervertebral discs. So this is an exam situation. You've done your MS, yes? Yeah. Okay, fine. Tell me about intervertebral discs.
It's got a central lateral nucleus pulposus and the
Okay, so now you're telling me about the anatomy of the intervertebral disc. Yeah, fine.
the outer layer is annulus fibrosus.
Yeah.
So I think it's a derivative of the notochord.
Beautiful. So you're going for the embryological, and then what else? So it's got a central annulus, a central nucleus, an outer annulus. It's the embryological remnant of the notochord, which is correct. What else can you tell me about the annulus? Tell me about function. So you talk about embryology. You talked about gross anatomy. You can go into the molecular anatomy. You can go into the function. You can go into pathology. You can go into management. These are the kind of things you talk about when someone gives you an open question like, "Tell me about this structure." So you've talked about annulus. You've talked about nucleus pulposus. Tell me a little bit more.
So it kind of provides a cushion between the two vertebrae.
Good, okay. So cushioning is correct, but it does more than cushioning, doesn't it? So it provides tensile strength and compressive strength. Which part of the body, which part of the disc provides tensile strength?
The annulus.
Correct. And which part provides compressive strength?
The nucleus.
So if you can say that in the exam, that's all you need to know about discs, really. And then you have to do a few things like draw a diagram of the crisscross fibers of the annulus, yeah? And that's why it gives you the tensile strength. And they'll ask you a little bit about the structure of what the nucleus is made of. And what is the nucleus pulposus made of? Proteoglycans and hyaluronic acid. Okay? Fine. So where does the disc get its nutrition from? Iris.
Just by diffusion.
From, yeah.
Neural and say that's
Yeah. Does it have a blood supply? Yes. Peripherally, not centrally. Does it have a nerve supply?
Again, just peripherally.
Correct. That's why when you have annular tears, you have pain. Now, what is a slip disc?
So it's a tear in the annulus fibrosus, such that the nucleus pulposus then herniates.
It's actually herniated nucleus pulposus. Why are they painful?
Because of substance P and the irritating.
Good.
pain.
So you get inflammation and you get high intensity zones, right? So it's actually not a mechanical compression necessarily that causes the pain, which is why even though you have a mechanical compression present on an MRI scan up to God knows however long, 10, 20 years, you may not have any symptoms after 6 weeks because the inflammation is gone. Okay? So that's why when you see a slip disc, you don't jump in and do a discectomy. 9 times out of 10, within 6 weeks to 6 months, it's going to resolve spontaneously. Okay? Fine. There you go. There's your structure, the crisscross that I was talking about, the lamellae, yeah, that's what they're called, of the annulus fibrosus and your nucleus pulposus. It's easier to be able to draw something like this for your FRCS. Okay. And this is a representation of the tensile strength and the compressive strength that your nucleus pulposus and your end plate is giving you. And it also gives you an understanding of why you get disc bulges. So if you have any weakness in the annulus, as happens with time, or you have any pathological state, then you get bulges in the disc. And what sits behind the disc, Anu? In the lumbar spine?
The spinal. So quarter quine.
Good, called a fecal sac rather, okay. Fine, okay. So, static disc pressures. This is a very important slide, and I think this is actually very telling, right? If you look at the pressure that is exerted onto a disc, in what position in what position do you think your disc is most loaded? Don't look at that picture.
So I thought when
When you're standing up, right? But that's clearly not the case, otherwise there wouldn't be any point asking this question. That hashed box over there shows that standing is more loaded than lying. Yeah? And lying supine is the best compared to lying prone. So lying supine is the least pressure on a disc. When you lie prone, you put more pressure on the disc. When you stand up, you put a bit more pressure than when you're lying down. Interesting that sitting loads your disc. We're talking about 4, 5, 5, 1, the lowest two discs, yeah? In fact, this is the third lumbar disc. So 1, 2, 2, 3, yeah, 3, 4 this is measuring. Sitting is actually worse than standing. Stooping forward is worse than sitting. And slouching in the seated position is the worst position you can have for your lumbar discs. And what do we do all day in office-based jobs? In clinics, everybody's slouching. Yes. So this is an important thing to understand, because this is something we never think about. We always think that standing, running, axial loading is going to be the worst thing. Actually, slouching in your chair is the worst thing you can do for your disc. Okay, so slouching in itself, not only is it poor for your core and all your active stabilizers, etc., but the action of slouching itself puts huge forces through the 3, 4, 4, 5, 5, 1 disc. Right, independent of the poor other effects. Okay, so that's something to be aware of. So I tell patients as a rule of thumb that sitting forward puts in about 3 times as much, slouching is 3 times as much load as standing. And in fact, I said that before I had seen this, because I read the paper somewhere, but this demonstrates exactly that. Okay, so 3 times as much force is going through the L5 as well, 4, 5 discs, okay? Now, discs express all the features of any other structure that you have in the body. So when you talk about cartilage and the properties of cartilage, cartilage is viscoelastic, so it has stress-strain behavior, so does disc. Anisotropic, that means depending on the way you load it, the mechanical properties vary. It has creep, and it also shows hysteresis. Anyone can describe hysteresis for me? Iris?
So when the loading and unloading curves are different, and
Correct.
the difference
Yeah.
in it, just the energy
Yeah,
response.
exactly. Loss of energy under repetitive load-unload cycles. Okay, hysteresis. Yeah. Okay, so now pathological states in the disc. What's the first sign of disc wear usually? On the T2 images, what happens to the disc?
Dehydration.
It gets dark. Yeah. So what looks bright on T2 MRI?
More.
And fat. Okay. So if it looks dark on T2, it's probably got less water, loss of water, dehydration. Now it says end plate damage here affects nutrient flow. I agree with that, but yeah, that's fine. But what else do you get when you have disc wear? Dehydration, yeah, and then? So what happens when the nucleus pulposus dehydrates? The disc bulges. What happens when you deflate a balloon? It becomes floppy. Yeah, so the disc becomes floppy. Yeah, as a result, it bulges out. That was what that picture earlier on was trying to show you here, right? So when you lose your compressive pressure in here, yeah, the disc bulges out. But the disc bulge is not the same as the disc prolapse, right? It's just a disc bulge. A disc bulge can be pathological, but is usually asymptomatic, usually. And here you can see that it converts the annulus from tension-bearing to load-bearing inward folding. You understand what that means?
What do you mean by inward folding?
If you have fluid inside a balloon and you load it, yeah, the water, as long as the balloon walls are tight, will hold everything up. If you deflate it, it folds in on itself, yeah? And then, instead of being something that's inflated, it starts becoming load-bearing. That's what this means. That's the pathological state. That's your disc collapse that you see. And then after that, you get end plate reaction, then you get your modic changes, and you see the changes in the end plate bone. And you see your modic changes are the name given to the changes seen in MRI, and there are 3 types. And essentially, they represent the progression from inflammation or some kind of reactive change to sclerosis. Okay? When it's sclerosis, it's usually burning out or burnt out. Okay? And annular clefts allow extrusion of nuclear material. That's your nucleus pulposus herniation that we talked about. Okay? Fine. Now, ligaments. Name me some ligaments around the spine. Okay, so starting at the front, ALL, and then PLL, posterior. Where does the PLL sit?
The posterior.
Posterior aspect of the vertebral body.
Just behind the posterior wall of the vertebral body, in front of the fecal sac, yeah? So to have so why is it that whenever you get a slit disc, you hardly ever get it coming straight out the back?
Yeah, that's the way.
PLL stops it. That's why it goes out to the side. Yeah? Okay, you ever wondered why? Sorry, that's why it happens, okay. What are the other ligamentous structures?
Spinous.
Hmm?
Spinous.
Interspinous is correct, what else?
Supraspinous.
Supraspinous,
Ligamentum flavor.
ligamentum flavum. Where is the ligamentum flavum?
So just posterior to the theta. So
Yeah. What is proximal, distal, medial, and lateral insertions of the ligamentum flavum? The leading edge of the lamina of the level below to halfway up the lamina on the ventral surface of the level above. And it's not one long structure, it's little posterior segments. Medially, it goes all the way up to the SP, but in the lumbar spine at some levels it's deficient in the midline. Laterally, it goes up to the medial hemifacet. Okay? So, what are the function of the ligaments? What does the ALL do? What does the PLL do? What does the flavum do? These are all,
It provides what?
they're all passive stabilizers of the spine. They're not active, they're passive stabilizers of the spine. Okay? And surgically we take advantage of them. So for example, when you do an indirect decompression by putting a cage in between two vertebrae, you depend on the ligamentotaxis you get because of an intact ALL. If you don't have that, you can't do the operation. For certain types of procedures, for a T-lift or an X-lift. If you go from the front, you divide the ALL and you lock it at the front. So there are lots of different things you can take advantage of. All right. So what have we talked about so far? We talked about the ALL, we talked about the PLL, we talked about the, did we talk about the inter-TP ligament or the intertransverse ligament? I didn't mention, I should have mentioned that to you. I didn't think about it. You guys got everything else. You got the interspinous, you got the supraspinous, you got the flavum. I thought about the inter-TP and I didn't mention it, and there's the facet capsular ligament as well. Facet, the capsule. The facet is a primary or secondary cartilaginous joint. Anybody? Why is it secondary? Is it a midline structure? I don't remember, to be honest. I'm just checking if you know. But essentially, it's a facet is a proper joint, right? So it'll have a joint capsule, it'll have synovium inside it, so it has a capsule as well. Okay, and there's a ligament associated with that. So, muscles around the spine. I mean, spine biomechanics is not quite the same as hip biomechanics because it's a midline structure, it's differently loaded. You can do a free body diagram for the spine, and I did learn to do one for the exams, but nobody will ask you that because it's not really necessarily relevant. Okay, so spine biomechanics is all about structure, function, movement, and stability. Okay, so the muscles are a part of your active stabilizers. We've talked briefly about the muscles earlier on, haven't we? Yeah. So what are the muscles again? Just to recap, probably do you remember?
Iliopsoas, quadratus lumbar, posterior spinal.
Yeah, which are? There are three. You can name them in two groups if you like. Your rectus spinae and your multifidus. Okay. Now, that's just looking at the spine itself, front and back. But there are other structures that confer stability to the spine. What other structures could they be? Anya?
So the actual facetals themselves?
Active stabilizers.
Active, sorry.
Anterior-abdominal wall, transversus abdominis, your obliques, rectus abdominis, pelvic floor, diaphragm. Okay, all of that supports the spine, the whole trunk. It's right deep inside it is your spine. So it's not just a question of having strong psoas, you need to have strong, good anterior-abdominal wall, you have to have strong pelvic floor, your diaphragm is very important. And all of these structures, your stability also contributes to the function of different structures. So your spine stability will also help with breathing, for example. Okay, because your diaphragm is one of the core stabilizers, and everything is connected. Fine. Now, neural tissues, right? So earlier on we talked about what comes out at L3-4. Let's look at L4-5. What the traditional teaching is that until C8. The nerve associated with the level comes out above, otherwise it comes out below. So at L4-5, you have the L4 nerve root coming out. Well, when it comes to pathology, that's actually not strictly true, because at L4-5, if you have a disc prolapse, it's almost always going to be a paracentral disc prolapse. And it's not going to be a central disc prolapse because of the PLL. Yes. So if it's a paracentral disc prolapse, what nerve at L4-5 sits in the paracentral zone at the back of the disc? The L5 nerve root. Yes. And that's because the nerve root doesn't just come out laterally and pop out in the lumbar spine. In the cervical spine, it sort of does. In the thoracic spine, less so. Definitely not the lumbar spine. For the same reason why, even though the embryo has one discrete, or the spinal cord from top to bottom, by the time it becomes human, at the bottom you have the chordae equina. The spinal cord doesn't grow at the same rate as the vertebrae. So it's as if the vertebrae at the bottom are growing and they're pulling bits of the spine out with it. So the takeoff for the nerve root is a little bit higher than the associated foramen. So it comes off at the thecal sac at the level above in the paracentral area. So while the L5 nerve root exits at the L5 foramen underneath the L5 pedicle, actually comes off at the L4-5 disc space in the paracentral area in what's known as the lateral recess. And that's why, if we have an L4-5 disc prolapse, you catch the L5 nerve root, almost always.
Do you have to get S1 as well?
At 5-1, you get S1, yeah.
But
No, the
S1
takeoff.
passed
So,
away there as well.
so you're right. So the origin of the S1 nerve root by that time is still very much inside the thecal sac. Okay. So there, at that stage, there's still the rootlets of the chordae equina. Okay, it's not a nerve root yet. Then it takes off a sleeve of dura, comes out in the lateral recess, goes down across and out at the level below. And it's not just a sideways movement either. Depending on which level, it can come off actually quite ventrally and come out, go out dorsally, down and around. So it has a number of movements and twists and turns that it does before it comes out. And that understanding that helps us treat it surgically and undertake invasive procedures, knowing exactly where it is. And it's not all the same either. Okay, fine. So that's a basic principle for you guys. Most of you should know that already. I think all of you have done a spine clinic with me at some point, haven't you? So we would have discussed something. And you haven't.
No.
You should.
Your turn will come to me.
Okay.
You look forward.
Fine. So let's talk a little bit about lumbar canal stenosis. I know this is spine biomechanics, but it's important. I think it's useful to know. When you get your lumbar canal stenosis, that picture demonstrates the stenosis nicely, right? But there are 3 arrows. So what is it trying to show you? It's trying to show you that your stenosis is not just one thing. It's not just a disc that's popping out. What else? The disc is what we think of as the primary structure. What else could it be that compresses? We mentioned ligamentum flavum. Does that get hypertrophied? Yes, it does. So you get flavum hypertrophy from the back, disc prolapse from the front. What's the third structure that becomes abnormal in a stenosis situation? Facet. Your facet becomes hypertrophied. Why does your facet become hypertrophied? What are the 4 radiological features of osteoarthritis? Go on.
Subchondral sclerosis,
Yeah.
space narrowing, osteophytes.
Osteophyte formation.
Osteophytes.
So osteophytes. So what are osteophytes?
So they're a way that the body tries to compensate for increased load by spreading the load over a larger area.
Yeah. So when you, but why would it want to compensate? Because the cartilage is big.
It's cartilage line.
Yeah. So there's abnormal loading of the joints of the subchondral bone, and it's a response of that bone to the increased load across it. Yeah. So you get hypertrophy. It's the same way you get osteophytes in the facet. Then that's why you get facet hypertrophy, and the circumferential reduction in the space available for the nerves causes your lumbar canal stenosis. Okay. Just gonna have a quick look at this. Right. We talked about the foramen. We talked about the nerve roots. Whereabouts in the foramen does your nerve come out in the lumbar spine? Yeah, top of the foramen, just underneath the pedicle. Yeah, so that's the exit. In the cervical spine, it's a little bit different. Okay? And that's because remember how we talked about the spine dragging the nerves through? Yeah, in the lumbar spine, it's dragged it up from above. In the cervical spine, it comes right out. cervical spine is usually towards the center or the lower end of the foramen. In the lumbar spine, it sits at the top. It's tethered to the pedicle. And that's a demonstration of it being in the lumbar spine at the top of the foramen, directly underneath the pedicle. We briefly talked about kinematics earlier on, and kinetics and the difference between the two. So kinematics is the study of motion without reference to the force or mass, and kinetics is the study of motion of a body under action of given forces under movements. Okay. Fine, I'm just going to take you to a different presentation now because I think we're done with this one. We don't need to do it at all.
That one's from Cardiff, is it?
Yeah, I nabbed it from Chopra. Part of my research division. It was Monty who was going to do this talk, and then he was interviewing fellows, so I said, okay. Now, give me a minute, yeah.
While you're doing that, can I ask you a question? We always taught that people with spinal problems should not use crutches, would not. But actually find that crutches actually help.
I don't think it makes any difference whether or not they use crutches. What I don't want them to use is a lumbar brace or a neck collar.
How what doesn't help?
So the reason why people wear crutches, people use crutches is because of a number of reasons. First of all, if you have spinal stenosis, or you have a foraminal narrowing of some description, by bending forward you open up the foramen indirectly, and that it allows you to walk, allows you to not have pain. Now if you're doing that, you're very stooped forward and you're in positive sagittal balance, which means that your muscles have to work overtime to hold you upright because you're not in a balanced position. As a result, you get back pain. So those patients find it beneficial to have crutches or a stick. But as far as the spine is concerned, in my opinion, it makes no difference whether you use a crutch or not. It's a crutch being a reflection of another pathology. What I don't like is wearing a corset, because that decompensates the muscles around your back. So if you have low back pain to start off with, and wearing a corset to offer an external stabilizing force into your spine, I'd rather you did that intrinsically with core strengthening than use a corset, which ultimately you will decompensate further with. So this is the talk that Monty wanted to give you. There's a lot of overlap between the two. Okay.
Just go back one slide. Is that Monty? There.
Just take a little bit too.
Have you done it already?
I'll just show you. There's a lot of overlap, so I'm not going to show you everything, right? So we talked about a few things, earlier on. We talked about lordosis, cervical kyphosis. A baby spine, how is that different from an adult, do you think? How does the spine change as you grow? When you're born, what's the shape of your spine? It's just a straightforward C. What's the first curve to appear in your spine? Your cervical lordosis. When does that appear? When you can hold your head up. When is that, usually?
7 weeks. 6 months.
Yeah, exactly. 6 to 12 weeks, okay. And then, when you learn to stand, that's when you have your... Sorry?
We all heard that.
You still haven't learned, right? Then when you learn to stand, that's when your lumbar lordosis appears, okay? So these are important numbers to remember. These are normal figures for your curvatures of the different segments of the spine. You're looking for between 20 to 40 degrees of a cervical lordosis, 20 to 40 degrees of a thoracic kyphosis, and 30 to 50 degrees of a lumbar lordosis. Sometimes you could have more of a lumbar lordosis. The lumbar lordosis is quite variable. It depends on person to person. It depends on a number of features. And actually what's a normal lumbar lordosis is decided by the relationship between the position of the hips and the sacrum. So there's something called the pelvic incidence, and that's how you decide what's normal for that individual. Okay. I'm not going to go into pelvic incidence and these numbers. No point. We've talked about what a motion segment is. We know what it is. Carl described it earlier very nicely. So 2 adjacent vertebrae and the intervertebral disc in between, and there are 6 degrees of freedom within each motion segment. What I wanted to talk to you about, which is what I was looking for in this, is the orientation of the facets as you go from top to bottom. That's an important thing. So we talked about hysteresis earlier, that's all here as well. So someone tell me about the orientation of the cervical facets. Swan. Ah, Monty, you're here.
I'm here now, yeah.
I gave you credit, don't worry.
Yeah, oh, don't worry.
Yeah, he was here when I made the joke about is that Monty.
Was he?
Yeah, of course. Why do you think I
I
said it?
didn't realize that.
I thought you were referring to the guy in the picture, the part, you know.
Yeah.
Oh, is that what you meant?
Yeah, go on the left.
Okay.
Yeah.
Similar head.
So, Swan, tell me about cervical facets. In which plane
This
do
wasn't
they
meant to
sit?
happen.
Um,
Literally just like
it's
that.
in
Yeah, literally. Okay.
Really?
Okay.
Cervical.
the one that sticks out the most.
Okay. Imagine your lumbar facets are like that.
Yeah.
Okay, 15 degrees to the AP plane. Your cervical facets are like this. Okay, and your thoracic facets are go across. So your facets start off like this in the cervical spine. Yeah. So they're facing forward. Yeah. And if you look at a cervical spine facet, it's oblique. When you look at it laterally, but it's pretty much facing front to back. And then as you go to the thoracic spine, it's similar. The thoracic spine is very similar to that. And in the lumbar spine, it starts to become facing side to side. Okay. Why is that important?
It reflects the function at that level of the spine. So
Yes.
at the longer spine, you get more forward flexion.
Correct.
And
Exactly
the
right.
spine rotation.
Perfect. So if you know that, that's probably enough. There are various numbers, the exact numbers. It's in fact in Manoj's book, Biomechanics of the Spine section. All the numbers are there. But if you understand that, that's much, for me, that was much more useful than remembering the numbers. Just imagining the cervical facets to be like this and the lumbar facets to be like that. That really put it into context. We've already talked about instability, Punjabi and white. We've shown you this we've already talked about this one earlier on. What else was there to discuss? Moment arms. This was the one thing. So we talked about a free body diagram, yeah? Okay, this is what a free body diagram in the spine will look like. No one's going to ask you to draw it. Monty, do you want to elaborate a little bit more on this? Or are you good?
So who's coming up to their exam? Anybody? You? Okay, that was a very small. Okay, so I mean, I guess what is this trying to explain here?
So the further away
And
you are
also
from the
question
centre
B,
of
the question, second question is how do we fit that in practically to our lives?
I guess they always emphasize it in manual handling where you should keep the load close to your body because the moment arm is then lower.
Yeah. So what are the various forces going on here? So you've got the load of the thing that he's carrying, yeah, and where's the counter force to that?
It'll be your posterior spinal muscles.
Yeah.
Which is where? Where is that?
There.
So that, or that? Is this. Okay. And how far from the center is that? And what kind of a distance is it having to compensate against? How much force did it have to generate to compensate for that?
The distance not shorter than the.
What's the distance? 6 centimeters.
Mm.
That's why if you're too forward, you fatigue.
So yeah, that's why I was giving that advice. To when you lift a child, for instance, that's the worst thing you can do. You pick a child up from a cot, and they say the most important advice you can give a new dad and new mum is to lower the cot down so you can actually walk into it and bring them up like that. If you come out and pick them out like that, especially people, you notice how they're giving an image like this where you're doing like a squat, back straight, and you're going like that. What people do is they bend over like this, and that's the worst possible thing you can do because the only thing you're engaging is your posterior muscles. And you've got it at arm's length, obviously that's a large moment arm. It's only 6 centimeters going the other way, so you've got to make them match up in terms of Newton meters. And so that's why the load going through the posterior spinal musculature and into your disc is massive. So that's why you always hear like people that go and deadlift, they're not doing it properly, they'll say something went.
So you tell me I've got the 3 kids and
Yeah. So the amount of
I always pick up my cats like that.
sorry, I shouldn't have been like human racist or whatever. If you're picking up a child or a cat or a dog.
Very good catch.
Yeah. So you wouldn't believe the amount of dads I see with back pain when the wives are pregnant and just giving birth. And you think, and this theme kept recurring. And then of course it's because they're doing a lot more lifting around the house than they start lifting babies. And so
The other thing you do as well, if you walk around like that, how long is
yeah.
That's how we all get scoliosis.
So when people say, should I deadlift, should I learn how to squat? Of course, because that's what you do every day in life. You just don't need to do it with 80 kilos. You do it 5, 10, 15, 20 kilos. And that previous diagram about, what do we call bad posture when we're sitting down? That's a really nice one to explain to patients. It's like the force going through your disc at this is almost
3 times as much as when
yeah,
it's standing.
it's a massive amount more. Yeah, when you're bent like that, then compared to this, which is the second least amount of force, compared to lying down, which is obviously the least amount. So when someone says to you, "Should I cycle?" it's not no or yes. It's how do you cycle? If you cycle in that position, you're bent and your neck's extended. If you cycle with your handlebars up and everything, then it's a completely, it's a very low impact position to be in. Same with anything. Most things are okay to do. It's just how you do it. You do a lot of training, don't you? Was it you? No. No. Someone was talking to me about. It was like late. It was pretty late into the night when someone was talking
Just
to me
to,
about training the other
What
day.
about
If you
If
find
you
already
look at
pathological.
Manoj's book's chapter,
Actually,
talks
I'll
about exactly what we talked about passive
Sorry, what
active
did you what?
neural systems. We talked about the vertebrae, we talked about the basic anatomy of cervical versus thoracic versus lumbar spine. Here we go. These are the orientations of the facets. Looking straight up. So you see, this is what I meant when I said the facets in the cervical spine are straight up and down, and the lumbar spine are like that, and the thoracic spine are somewhere in between. That's looking at it dead on, okay? If you look at it from the side, it's a little bit different. 45 degrees, look at it sagittally, it's 60 and 90 degrees in the lumbar facets. But it's not as hard and fast as that, okay? It changes even within the lumbar spine. And I think we've actually covered more than there is in this chapter. I think that's it. Okay? Anything else you guys want to ask?
So I'll ask you questions then. Why do people you hear stories of people coming to A&E and they say, I was on the floor for, I was lifting a bit of furniture and then I was on the floor for 2 days, I couldn't get up. Are they making it up or is it what's happening there? Any ideas?
Are they just lying down to put the least amount of pressure through their vertebral disc or something like that, just a physiological response?
So you'll hear men say, oh my God, it was terrible. You even hear some women say, God, that was as bad as pregnancy. What's going on there? You could put that diagram up with the nerves, could you?
Yeah.
This is a really important thing to appreciate, to try and appreciate why people come in with. There's no such thing as non-specific back pain. You'll see this written over there. Unless someone's landed on you in a rugby match or something, there's no such thing as a muscular strain. Or if you've been hit by, it's the other one, that axial picture with the little nerves going into it. Keep going. Should still be there. There's that picture I took from the book. Is there another? That's one. Okay. So, if you get hit by a car or something, or if someone lands and you can have a muscular strain. The people that come in with back pain, they get put down as muscle spasm or muscle strain. There's no such thing as that, unless you have an accident. So what's going on there? It's a really important thing to realize because most people present like this. I've given you a big clue here with this.
Posterior disc protrusion.
Yeah, but what does this statement here say? The paravertebral muscle innervation is highly connected to the disc.
Yeah. So if you imagine the disc here, it's there, and you've got a slightly unstable, you've got an unstable disc, which, you know, when you lift, it's moving. What happens is you get this massive impulse to the paravertebral muscles, and they contract, and of course they're massively strong, as you can see from the moment arm diagram. They have to be strong in order to counter that. So when someone says, "Oh, I was on the floor with muscles," the muscle spasm is not a diagnosis. Muscle spasm is a secondary effect, and the most common cause is, you know, when people say, "I was lifting something, or I was twisting, or whatever, and I had this massively gripped," and it's normally because the disc is moving, it's unstable, and then they'll tell you, "Oh, and 2 weeks later I started getting leg pain." Yeah. So the other reason you can get muscle spasm is from facet pain. Yeah, so it's for any joint pain. I've got AC joint pain at the moment. Where am I getting pain? Up here, up here, up here. If you get L5S1, L45 facet pain, you get muscle spasm. So the key with any of these people is that they'll present with this diffuse pain that you shouldn't just fob off. You know, say, "Oh, it's there, it's everywhere," but there's normally a driver which you have to try and distinguish. You know, if it's facet joint pain or inflammation, you have to try and get rid of that. And then you have to deal with muscle spasm. And then the third bit is you have to try and help prevent that happening again. And that's why people talk about physio, about Pilates, about rehab, about lumbar pelvic stability.
Why do you think the muscles have the same innervation or similar connected innervation to the annulus?
It's got protective roles.
It has a protective role, yeah. And you know, we talked about the active stabilizers. Yes, muscles are an active stabilizer of the annulus, which is something that's a passive stabilizer. The passive stabilizer on its own is insufficient to hold the spine upright. You need to work in symphony. But it's also maladaptive response to an extent, yes?
It's a maladaptive response, so it's control. So what happens when your glutes go weak? What does your body do? Do you know? Yeah, to a certain extent. What happens around your hip joint, around your hips? So next time you see someone in spine clinic with an L5 nerve root issue, have a look at their glute wasting, then have a feel of their hip, like the front of the hip, and then start rotating the hip. And you'll find that they're often very, if you know where the sartorius tendon is, right below the ASS, you follow that down, you'll suddenly find them going, ow, ow, ow. And then you rotate that hip, it doesn't move as well as the other one. And that's like a classic finding. And the reason is because your glutes are stabilizers. Yeah, they're part of the lumbar pelvic stabilizers. So what happens is your body thinks, okay, how do I stabilize now? It grips like that. And you'll often find people with L5 nerve root issue saying, you know, I've got pain here. That's not an L5 nerve root distribution, it's just muscle gripping. So one of the first things a physio or Pilates instructor does is try and get you hip dissociated, try and get your hips moving properly before you can move your back. Why? Because if your hip is gripping, if your muscles around the hip are gripping, your glutes are weak. When you walk, you won't just be moving your hip by doing this. You will be moving your entire pelvis. When you move your entire pelvis, you're basically causing facet pain. So that's why you hear physios talk about hip dissociation. Because if you can move the hip separately, then you're not impinging on your back all the time. So it's a maladaptive response. So it grips, but then it actually worsens. If you don't release it, and every time you make a movement, you're moving your lumbar pelvic, your lumbar sacral region. So, yeah.
So people go and do a posterior rise off. I think what's your opinion about that?
No, you mean by radio frequency ablation?
Yeah,
Yeah.
nowadays it's radio frequency. In the old days when I was growing up, you just go and cut them.
Yeah, no, that's
Sounds
right.
very destructive.
So what they try to get rid of is people doing facet joint injections. All we've done is change the terminology to medial branch blocks.
Some injection.
And then put the price up.
Yeah. Well done. Do you do anything differently technically?
No, the medial branch is in a slightly different location. it's difficult to show in this photo, but you've got your basically your transverse process where it meets the facet joint, and basically your aim is between the transverse process and the facet joint for a medial branch, whereas the facet is obviously slightly more medial. I was being slightly cynical, but it has stopped people who do multiple facet injections, which we never did here anyway, from doing that. So you do a medial branch block, so you blast the medial branch and you see, okay, has that relieved the pain even for a week or 2 weeks? And if it has, then therefore technically your radiofrequency ablation of that same place should work. And the results are pretty good. If your medial branch works, then the radiofrequency works about 80% of the time.
Okay.
And it'll last for a long period for about 80% of the time.
That should bring that all back.
Yeah. So the key to, like, I mean, we tend to see quite chronic pathology in the clinic, but the key in clinic is there is no such thing as non-specific back. People just don't come in with, you know, unless they've got vitamin D deficiency or they're making it up because they don't want to work or whatever.
Yeah.
There is always a driver or several drivers for pain, and we do quite regularly do SPECT scans now. Have you guys come across this? SPECT scans, they're basically, it combines the effects of a CT scan and a PET scan and a bone scan, and gives a 3D image of osteoblastic activity. So often we'll see people with multiple disc degeneration, they've been through pain clinic, they've had physio, they've done everything, and they say, oh, is there anything you can do? And you say, well, it might be L5S1, could be L34. We do a SPECT scan, actually one of them really lights up. And that doesn't happen infrequently, right?
No, I have very frequently.
Yeah.
It really helps you make a diagnosis.
Yeah, basically make it up.
So what Monty said is absolutely right, that there's hardly ever pain without a reason. But that doesn't mean the reason needs surgical management. Right. Usually it helps you focus your treatment, focus your therapies, focus your physical rehabilitation towards it. You may want to give it an injection, you might not want to, it doesn't matter. But it helps target the treatment, which is what you want to do. You don't want to just willy-nilly dismiss people with back pain.
There's only there are two reasons mainly to do an injection. The patient's really not fit for surgery, or to give them a relatively pain-free period of time to in order to relatively pain-free period of time to carry out the rehab.
What's all that?
It's very noisy.
What?
That's a hell of a-
You want to go to the pub, is that?
Yeah.
Can I just ask, in terms of your history, is there any sort of key question that help to distinguish very defensively about where?
ABC Spine, ABC Orthopedics, you need to read the spine chapter written in that. That's all the key questions.
Yeah. There are the specific basic ones that they mention about differentiating between flexion-based pain and extension-based pain, diffuse pain, sharp pain, dull aches. People will talk about the gripping pain or muscle spasm. That if someone says to me, like I said, I was picking something up, it just gripped me. That gives you a disc-like history. Facet pain doesn't do that. The extension type pain. Instead of, well, I feel better when I lean on the trolley or something like that. Obviously, leg pain. But it's other than that is really your typical kind of neurological history that you look into.
With respect to the nature of the pain, there's some very broad generalizations, very much in keeping with what Monty said. Very, very broadly speaking, if your pain is worse when you arch back, that's when you're loading your facets. If your pain is worse when you bend forward, that's when you're loading your discs. Okay. And there's a few other things that we'll need to look at when you're looking at a patient. So they'll say back pain, but back pain is not just one discrete, one amorphous structure. It has lots of different facet parts to it, right? So if you ask them to point to where the pain is, often they will point, it's here, or there's a few ways. Like when people talk about facet joint pain, they usually say that the pain is kind of like this, and they literally do this movement across their low back. It's almost always facet-related pain. When it's not related to that, or it's muscle spasm, or it's poor posture, or it's sitting slouched, they usually describe a muscular pain on the side like that, on one side or the other. And that's when they're doing this, it's usually less likely to be something structural. Okay. And then the biggest distinction that you want to make in your history is whether it's back pain or leg pain. So if it's leg pain, it's significant because that's usually neurological. And again, you always have to be mindful of the fact that it could be a hip pain, it could be a knee pain. Many people have done decompressions and all kinds of things without realizing that there's a stalking arthritis in the hip in that level. So I have a knee-jerk response to do at least an X-ray of the hips if someone has low back pain at the same time. Just do it every time. So back pain versus leg pain, and within the back pain itself, you want to differentiate between where the pain is, how they're describing the pain, and when they get the pain, right? So if the pain is sort of made better with movement, so people with facet type pain will typically describe getting up in the morning and feeling stiff for a bit. You have to then differentiate that from rheumatological pain, and that it takes a little while to get going. If they're sitting down, they say, I seize up if I sit down. That kind of, for me, generally means facet type pain. When the other thing that you can do is actually press down in the paraspinal areas and ask them to arch their back. And again, people who have facet type pain, they will say that makes my pain a lot worse. People who have disc pain will often feel relief with that kind of thing.
So, yeah, go on.
I know there's a diagnosis of exclusion rules to prepare from litigious starting hours, but are there any sort of tidbits when someone put it on for work that instantly, they say something that instantly makes you think, oh, it's highly likely that it's...
You got your Waddell sign.
The Waddell signs, yeah. In the history, I mean, it's the normal, things you look for in any history, really. Inconsistent, non-myotomal, dermatomal. They'll say things like, oh, it doesn't really progress, it's there all the time. Just the normal things. In terms of signs, the Waddell signs, if you look them up, they talk about, pain on axial loading, resistance when you do a straight leg raise. The patients who are generally doing it for work compensation or whatever will think that pushing down your head actually relieves, or it actually brings on pain. It almost never does unless you've got C1, C2 symptoms. If you've got sciatica or radicular type pain, they often try and resist because they think that's that shows that you're in pain. But actually, people actually can't resist when they're in significant pain. And then non-dermatomal patina, numbness, pins and needles. What I was going to ask was, what about buttock pain, Iris? What causes buttock pain? Someone says they got pain.
Okay, that's one reason. What are the other reasons you might have buttock pain? Which nerves might cause buttock pain and which nerve never? Okay, what else can cause buttock pain if it's not from the spine? What else can cause buttock pain? Tell me the anatomy of the sciatic nerve. You should know the anatomy of the sciatic nerve because it makes sense.
You will learn it all in getting
Yes, she said it.
Yeah, I mean, piriformis comes down my list, right? So you've got glutes there. People get gluteal inflammation. If you scan people who have buttock pain, there's quite a number of them will have some amount of gluteal inflammation or tendinopathy. That's quite common. I think some of them are subclinical. You've got your SI joint there. Yeah. L5 or S1 nerve root pain can present as buttock pain. So those are the most common things. Piriformis is much less common and difficult to diagnose. It's a process of exclusion. So those are the things you need to think about. Anyone with low back pain where you can't see anything in the lumbar MRI, you have to think about SI joint pain. SI joint pain can, if you look at the, there's some good studies that show the pain maps of where you can get SI joint pain. So it can be anywhere from halfway at your back down, halfway down your hamstring. I've done quite a number of SI joint injections where people have had hamstring pain and they've done the usual thing, they've gone to see a physio, sports doctor, whatever, gone to see the hip guys, nothing, done lumbar MRI, nothing, injected the SI joint, and actually all that hamstring pain is gone. So you can get SI joint pain, at any point from there to there. So you have to think about that.
You also get the facet joints, just as their embryological development is the same as the same, basically the saddle distribution. That's your thighs.
Yeah.
Just get, if you've got inflammation of the joint, you just get referred pain down in that area, and then capture it with the facet.
Yeah, just like the hip, you can get it down the knee road. The SI joint can be hamstring pain. And often I get it like quite far down the line when everybody's tried everything else and done stretching and ultrasounds and shockwave and various things. But it's something you need to think about. And remember that also when you do a lumbar MRI scan, it doesn't cover the sacroiliac joints. So for me, anybody that has pain around the lumbosacral region should get a pelvic scan because that's the only way you can see all the whole of the sacroiliac joint.
Of course, another common cause for buttock pain,
Yes.
don't forget, is the
The
hip
hip.
joint.
Yeah.
Because you can